Hey guys, Kathleen. This lecture is on evaluation and management of thyroid disease. The physiology of the thyroid gland is the endocrine gland is located just below the cricoid cartilage of the neck. It's important to know anatomically where you're palpating for that. You don't want to be too high up on the jaw. Part of what I do is put my fingers on the manubrium and actually feel for the bony prominences, and then put one finger breath above that, and that's exactly where your thyroid gland is. And it's a butterfly shape, so the lobes are on the side of that. You want to make sure you landmark and make sure when you're palpating the thyroid, you're actually palpating where the lobes are. The thyroid gland produces T3 and T4. It regulates growth and development. It regulates protein synthesis, and it regulates cell metabolism. This affects all organs. The negative feedback loop, this is like a good review in pathophysiology. It's a wonderful map. When we talk about the negative feedback loop, we're actually talking about the hypothalamus, which is in the brain. And you have TRH, which is thyrotropin releasing hormone, and that is released by the hypothalamus, and that hypothalamus releases TRH, and that stimulates the anterior pituitary, which is right here, to release TSH. And TSH stimulates the thyroid gland to release T3 and T4. So in normal homeostasis, what happens is you get a decreased thyroid hormones, T3 and T4. T3 and T4 stimulates the hypothalamus to secrete TRH, which is thyrotropin releasing hormone. And this stimulates the anterior pituitary to secrete TSH, which is thyroid stimulating hormone. And this TSH stimulates the thyroid gland to release T3 and T4 and then T3 and T4 increases in the blood, and then you get homeostasis. The level of T4 and T3 in the blood increases, and the hypothalamus stops secreting TRH. And that's where it's really important to maintain homeostasis. In hypothyroidism, what happens is you get decreased T3 and T4. You get decreased thyroid hormones T3 and T4. This stimulates the hypothalamus to secrete TRH, which is a thyrotropin releasing hormone, which stimulates the anterior pituitary gland to secrete TSH. TSH stimulates, just like I said before, the thyroid gland to actually release T4 and T3. But for some reason, the thyroid gland either no longer makes T3 or T4 or no longer responds to TSH. Either way, it does not release anything. So what happens is the hypothalamus continues to secrete TRH and in turn increases the amount of TSH. And that's what happens with hypothyroidism. You get an increased TSH because T3 and T4 is never released from the thyroid gland to maintain homeostasis. That's just a review of the pathophysiology. For the thyroid gland, a thyroid examination, you have to do a physical exam. You have to inspect, palpate, auscultate, the thyroid, you want to check for a goiter. And sometimes those goiters is really, when you visually look at someone's thyroid, it looks enlarged. The laboratory studies, you want to get a TSH, you want to get a T4, a T3. Do not get a total T3, T4. They're useless and they often come back falsely. You want to get a free T4 and a free T3. Depending on what the presentation is, you want to get thyroid autoantibodies. Not on everyone. You want to get antithyroid paradoxase, TPO, and antithyroglobulin autoantibodies. You might need to get thyroid stimulating immunoglobulins, TSI, and actually TSH receptor antibodies. So normal TSH, which is euthyroid, is 0.3 to 4 microunits per liter. Hypothyroidism is defined as a TSH of less than 0.3, and hypothyroidism is a TSH of greater than 4.0. Hyperthyroidism is characterized by an excess production or release of thyroid hormone T3 and or T4. The highest incidence occurs in women between 20 and 40 years of age. Female to male ratio is 8:1. Thyrotoxicosis is really a syndrome produced by excess thyroid hormone regardless of its source. Patients present with low TSH and an elevated free T4 level is diagnostic for hypothyroidism. Again, do not get a total T4. They're useless. You want to get a free T4 and a low TSH. Hyperthyroidism is less common than hypothyroidism in the general population. 50% of cases occur in persons greater than 60 years of age. Graves' disease, about 90% of hypothyroidism in those less than 40 years of age, and there is a genetic link. So thyrotoxicosis is another term for hyperthyroidism. So again, a free T4 is the most accurate test, a free T4. The etiology of Graves' disease is the most common. Also, you can have a toxic nodule goiter called Plummer's disease or subacute thyroiditis. The etiology is unknown. You can have silent lymphocytic thyroiditis, postpartum thyroiditis, toxic adenoma, or drug-induced amiodarone or iodine. You can have hormone ingestion, exogenous hormone ingestion, or increased pituitary production of TSH. Graves' disease is a common cause of hyperthyroidism, and basically it's an overproduction of the thyroid hormone, which causes an enlargement of the thyroid and other symptoms such as exothalamus, heat intolerance, and anxiety. And exothalamus is that those bulging eyes, if you will. Graves' disease is an autoimmune disease, results from thyroid stimulating immunoglobulin G antibody on the thyroid's TSH receptors. Autoimmune disease, also referred to as diffuse toxic goiter, it's caused by TSH receptor antibodies. So basically, Graves' disease is caused by a dysfunction in the body's disease-fighting immune system. When you have a normal immune system response, you have certain antibodies that are designed to target a specific virus, bacterium, or other foreign substance in health, meaning your normal immune system response is to produce antibodies designed to target a specific virus, bacteria, or other foreign substances. In Graves' disease, for some reason that is not well understood by science, the body produces an antibody to a particular protein on the surface of the cells in the thyroid, which is a hormone-producing gland in your neck. Normally, the thyroid function is regulated by a hormone released by a tiny gland in the base of your brain, which is the pituitary gland. The antibody associated with Graves' disease is called thyrotropin receptor antibody. Capital T, capital R, capital A, B is the mnemonic, if you will, if someone was to write for this. And again, that's a antibody associated with Graves' disease is thyrotropin receptor antibody. And basically, this antibody essentially mimics the action of the regulatory pituitary hormone. Therefore, this thyrotropin receptor antibody overrides the normal regulation of the thyroid and results in overproduction of thyroid hormones, causing hyperthyroidism. Signs and symptoms of thyroid disease are nervousness, irritability, palpitations, tachycardia, heat intolerance, increased sweating. These patients are on fire. Tremor, weight loss, alterations in appetite, frequent BMs, diarrhea, scant menstrual periods, pretibial myxedema, thyroid enlargement and changes in vision, and exothalamus. Myxedema is edema caused by the deposit of connective tissue components into the subcutaneous tissue. Pretibial myxedema typically presents in specific areas in the pretibial and then also the exothalamus areas in the eyes. And this is related to high levels of TSH receptor stimulation and or inflammation mounted against the TSH receptor itself. Myxedema of the lower legs, called pretibial myxedema, can occur in 1 to 4% of patients with Graves' disease, and this is a condition called hyperthyroidism. History and physical are key. You want to ask them, have they been exposed to recent iodine exposure? Medications that can cause this are estrogen, amiodarone, dopamine, glucocorticoids. You want to make sure you get a weight, vital signs. You want to palpate the thyroid and auscultate it as well. You want to do a good neuromuscular exam, a good eye exam, and a good dermatological exam. Differential diagnosis are anxiety, pheochromocytoma, acromegaly, mesothenia gravis, orbital tumors, and psychosis. Lab values. Normal TSH euthyroid is between 0.3 and 4 microunits per liter. Again, with hyperthyroidism, you're going to get a TSH as low or undetectable. You also want to get T3 and T4. You want to get a free T4. Remember that, a free T4 to confirm the diagnosis. Know that free T4 confirms the diagnosis. Free T3, approximately 5% have normal T4 levels. That's why it's very important to get a free T4. You want to get thyroid autoantibodies, and those are the names of them, in selected cases such as pregnancy, not in all. Radioactive iodine uptake test. Not everyone with hyperthyroidism gets this, or a thyroid scan. So hyperthyroidism is a TSH of less than 0.3. Hypothyroidism is a TSH greater than 4.0 microunits per liter. Potential findings with hyperthyroidism, you can have a T3 of 220 and a T4 of 12.5. A free T4 greater than 2.0 measures the amount of unbound T4 in the serum. Thyroid autoantibodies in Graves' disease. So specifically in Graves' disease, you have, again, that TSH receptor antibody. The TRAB levels are usually detectable 65% of the time. Anti-TG or anti-thyroparadoxidase antibodies are usually elevated but are not but are nonspecific. A serum ANA and an anti-double-stranded DNA antibodies are also usually elevated without any evidence of lupus or other collagen vascular disease. Also, a 24-hour radioactive iodine uptake test is used to differentiate between Graves' disease and multinodule goiter versus subacute thyroiditis and or silent thyroiditis. Graves and multinodule will have elevated, very important, radioactive iodine uptake. Okay, so Graves' disease and multinodule will have elevated radioactive iodine uptake. Basically, it's measuring how active that thyroid is. And with Graves' disease, you are going to have elevated radioactive iodine uptake. Subacute and silent thyroiditis will have low radioactive iodine uptake. The radioactive 24-hour radioactive iodine uptake also is used to determine the correct dose of radioactive iodine needed to treat Graves' disease or toxic multinodule goiter. The thyroid scan is especially useful to assess the functioning status of a palpable thyroid irregularity or nodules related to toxic goiter. Differentiating the features of conditions causing thyrotoxicosis, and this is kind of to tell you if you have Graves' disease, you most likely on exam, you're going to have a diffusely enlarged thyroid. You're going to have an elevated T4. You're going to have a suppressed TSH, and you're going to have an elevated radioactive iodine uptake. You're going to have an elevated radioactive iodine uptake. Multinodule goiter, you most likely will be able to feel a nodule. You'll have an elevated free T4, suppressed TSH, and again, an elevated radioactive iodine uptake. Subacute thyroiditis, you might have a tender, firm nodule, again, an elevated free T4, suppressed TSH, and then a decrease in radioactive iodine uptake. Silent thyroiditis, non-tender enlarged thyroid, you have an elevated free T4, suppressed TSH, and a decreased radioactive iodine uptake. Postpartum thyroiditis is usually most likely small and painless. You have an elevated free T4, suppressed TSH, and a decrease in radioactive iodine uptake. Hyperfunctioning adenoma, your gland will be firm, enlarged, you'll have an increased free T4, and you have a suppressed TSH, and again, an elevated radioactive iodine uptake. TSH secreting pituitary tumor, you'll have an enlarged thyroid gland, an elevated free T4, TSH that is normal or high, and elevated radioactive iodine uptake. Thyroid storm, with patients, they need to be hospitalized. Basically, thyroid storm is decompensated hyperthyroidism. Occurs after decompensated hypothyroidism. Stressful, life-threatening situations can cause this, such as trauma, infection, often precipitate this episode. Patients complain of feeling nauseous. They vomit. Abdominal pain may come before the storm. Signs and symptoms, they have high fever, confusion, cardiovascular collapse, malignant exothalamus, difficulty breathing secondary to enlarged thyroid gland. Treatment is antithyroid drugs, may be co-administered with steroids and beta blockers. Tachycardia is always present. That's really important. Patients can be agitated, confused, delirious, psychotic. They can be in coma with high fever and diaphoresis. Remember, these patients are hot, and tachycardia is always present. The treatment for hyperthyroidism is radioactive iodine, and it's used to destroy overactive thyroid tissue. Remember, this is an overactive thyroid. This is a treatment of choice for Graves' disease, and if they're going to have this treatment, you want to make sure they refrain from becoming pregnant for 4 months after therapy. You want to monitor T4 levels monthly, and every 3 months. And euthyroid should be assessed every 3 to 4 months for hypothyroidism. So you want to monitor TSH and free T4. So they can be a one-time dose, but know that first-time failure is approximately in 45% of the patients. Some require a second dose. Treatment for patients who have hyperthyroidism also have an increased lifetime risk of developing hyperparathyroidism. Lifelong clinical follow-up is mandatory with monitoring of serum TSH, free T4, and calcium. Precautions for first day: you want to delay the return to work, limit time in public places, do not travel by airplane or public transportations. For the second day of treatment for these patients who are getting radioactive iodine, you do not want them to travel on a prolonged automobile trip with others. Maintain prudent distances from others, 3 feet, drink plenty of fluids, do not prepare food for others, do not share utensils with others, flush the toilet 2 to 3 times after use. Precautions on day 5 to 11 is sleep in a separate bed, 7 feet of separation, avoid prolonged close contacts with children and pregnant women, and duration depends on dose of iodine given. Treatment for hyperthyroidism, antithyroid drugs, MMI or methomazole, MMI tapazole, is the first choice because it's long acting. Typically 15 to 60 milligrams in 3 divided dose, depending on the severity of the disease. These do have side effects. PTU is short acting with more rapid onset. Initial dose is 100 to 150 milligrams every 8 hours, And the treatment of choice for pregnancy, PTU is less likely to cross the placenta. Often used in patients of childbearing age or those awaiting surgical intervention. And remember that patients who are hyperthyroid, again, you need to consult with a specialist when someone has hyperthyroidism. Absolutely, absolutely, absolutely. There are side effects to these drugs, and a lot of times they're misdiagnosed because patients use total T4 and make this diagnosis, and it's not the correct diagnosis for hyperthyroidism. So you want to make sure you correctly diagnose and refer and talk to a specialist about, have them examine about the treatment of this patient with hyperthyroidism. Patient usually remains on these drugs for 1 to 2 years. Then the drug is gradually redrawn for the hope of permanent remission. Education: patients should call provider if they get severe sore mouth, sore throat, or fever. And this is a sign of agranulocytosis, which is a rare side effect of these drugs. May need to give both of these drugs at higher doses if patient is severely ill. You will not be giving these drugs in high doses unless you work with a specialist and endocrinologist. Monitoring with antithyroid drugs, you want to get lab tests. Again, the CBC, if you're looking for agranulocytosis, LFTs. During treatment, you want to get a WBC every 2 weeks for a month, and then every 4 to 6 months, and LFTs every 3 to 6 months. Duration of treatment is used for 6 to 24 months following euthyroid state. Doses then gradually decreased until the drug is withdrawn. They're followed up every 1 to 2 months for relapse, and many will have permanent remission following 1 to 2 years of treatment. So subclinical hyperthyroidism is very controversial. What happens is you get undetectable TSH, which is the low TSH with normal T4 and T3. You want to monitor annually for hyperthyroidism. Subacute thyroiditis often follows a viral illness. It's self-limiting. Anti-inflammatory agents can cause this. Anti-inflammatory agents are used to treat subacute thyroiditis. Prednisone. Following thyroiditis, you also can get a transient hypothyroidism, and you want to treat this with thyroid hormone. Surgical intervention. Patients may require subtotal thyroidectomy, total thyroidectomy, and these are useful for patients that are having compressive symptoms of the neck. Other treatment failures: a large gland, a multinodule goiter, or you suspect thyroid cancer. Hypothyroidism. This is the primary cause of hypothyroidism is chronic autoimmune thyroiditis, also called Hashimoto's disease. Some of the causes are radioiodine use or surgery can cause hypothyroidism. That's always the risk when you treat hyperthyroidism. Drug-induced by lithium, amiodarone can cause this, sulfonylureas, and radiographic contrast dye. Radiation therapy of head or neck disease, patients are at risk for hyperthyroidism. And secondary is pituitary and hypothalamic disease is also another secondary cause of hypothyroidism. Sulfonylureas, the cause behind that is that it actually decreases the uptake of iodine, causing hypothyroidism. And all of those drugs have anti-thyroid action, the lithium, amiodarone, sulfonylureas. Hashimoto's disease, most common cause of hypothyroidism in North America. The gland may take a small or maybe large form in Hashimoto's. When autoimmune thyroiditis coexists with a goiter, the condition is called Hashimoto's. This is familial. It's autoimmune condition. So what happens is lymphocytes become sensitized to an individual's own thyroid antigens, resulting in the formation of autoantibodies. So if you had to explain this, what does this all mean? Every tissue in your body expresses antigens on the surface, telling the immune system, hey, this is me. So you have HLA antigens. Those are the ones that are typed for organ transplants. So every tissue in the body expresses antigens on the surface, telling the immune system, hey, this is me. So this is the body's antigens. In this disease, in Hashimoto's, the lymphocytes stop recognizing the thyroid's antigens as me and instead see the thyroid antigens as foreign material. And because they stop recognizing the antigens as a me type of antigen, they create, so what the body does is create antibodies which attach to the thyroid and mark it for destruction by phagocytes and T lymphocytes. And the thyroid is eventually destroyed. So I want to explain that again, just to make sure I'm clear. In your body, in a normal state, a normal healthy body that does not have Hashimoto's disease, which is hypothyroidism, in a normal healthy person, every tissue in the body expresses antigens on the surface. And these antigens in a normal person tells the immune system, hey, this is me. And those HLA antigens are a form of the ones that are typed for organ transplants. Those are antigens that are they're expressed from the tissue, telling the immune system that these antigens are me. In this disease, the lymphocytes stop recognizing the thyroid antigens They stop recognizing the thyroid antigens as me and instead see it as a foreign material. They create antibodies which attach to the thyroid and mark it for destruction by phagocytes and T lymphocytes, and the thyroid is eventually destroyed. So when we talk about this as an autoimmune thyroiditis, it's the disease. In this disease, the lymphocytes, which is part of the immune system, stop recognizing the thyroid's normal antigens as me and instead see it as a foreign matter. They create antibodies, and these antibodies attach to the thyroid, mark it for destruction by phagocytes and T lymphocytes, and the thyroid is eventually destroyed. So some of the things that you want to look at is antithyroid antibodies, the thyroglobulin antibodies, microsomal antibodies, and TSHR antibody. This is far more common in females than males, and it does run in families. Signs and symptoms of Hashimoto's are fever, weight gain, dry skin, cold intolerance, coarseness and loss of hair, constipation, depression, irregular and heavy menses, hyperlipidemia, ataxia, hoarseness, goiter, bradycardia, memory impairment, and myxedema. Again, myxedema is an infiltration of the skin by polysaccharides, causing a waxy or coarse appearance of the skin. This leads to fluid accumulation, hyponatremia due to dysfunction in the renal tubules, and this can be very dangerous. Myxedema complaints, the patient, what often you'll see is thickened, scaly, doughy skin, enlarged tongue, muscle weakness, joint complaints, hearing impairment, bradycardia, possibly cardiac enlargement, pleural effusion, and ascites. Hyperthyroidism mnemonic is sluggish. So sleepiness, fatigue, lethargy, loss of memory, trouble concentrating, unusually dry, coarse skin, goiter, gradual personality change, depression, increase in weight, bloating, and puffiness, sensitivity to cold, hair loss, and sparseness of hair. What history is pertinent is signs and symptoms of hypothyroidism, family history, last menstrual period, pretty much a complete physical because the thyroid is involved in freaking everything. So you want to get weight, vital signs, heart rate, blood pressure. You want to do a good skin exam, an HENT exam, good neck exam, palpate neck and thyroid, including bruits, cardiac exam, respiratory exam, neuro exam. Lab testing for hypothyroidism, TSH is elevated. Free T4 is low. You have anti-TPO antibody. If you suspect autoimmune thyroiditis as an underlying cause, you want to get anti-microsomal antibody. Anti-TPO is more sensitive and specific. You also want to get anti-globulin, anti-thyroglobulin antibody because this is positive in 95% of patients with Hashimoto's. You might need a thyroid scan or ultrasound. Know that in hypothyroidism, TSH is greater than 4.0. Total T4 less than 4.5 can be indicative of underlying thyroid when TSH is also elevated. Low T4 with low TSH can sometimes indicate a pituitary problem. Free T4 is less than 0.7. T3 is less than 80. And thyroid scan may be needed to evaluate suspicious structural thyroid abnormalities. Subclinical hypothyroidism, TSH is elevated. Free T4 and T3 are normal. Treatment for a TSH greater than 10, patients who are symptomatic, patients who have presence of antithyroid antibodies, serum lipid abnormalities, a patient who smokes, and pregnant women or women with ovulatory dysfunction with infertility. So the treatment is thyroid hormone replacement, levothyroxine. You want to repeat TSH in 6 to 8 weeks after the initiation or change in dose. Usually the starting dose for adults is 25 to 50 micrograms a day. You want to titrate up 25 micrograms at a time. It takes 6 to 8 weeks to see effects when titrating dose. So change the dose and wait 6 to 8 weeks to recheck TSH. I usually wait 2 months. In elderly or coronary artery disease, you want to start with 12.5 to 25 micrograms per day. Know that adverse effects can be subclinical hyperthyroidism. Too much replacement can cause chest pain, palpitations, diarrhea. Too little replacement can cause fatigue, depression, and constipation. Examples of hyperthyroidism. Patient education, it's important to let them know this is a lifelong medication, that you really want to have them avoid the following food products, which can make your blood absorb less levothyroxine, infant soy formula, cottonseed meal, walnuts, and high fiber foods. You cannot switch patients between preparations of thyroid medication, brand name versus generic, because the amount of active medication varies greatly between these drugs. If patients switched, you must check TSH in 6 to 8 weeks to see if medication dosage needs to be adjusted. Levothyroxine Interactions, 4 hours before or 4 hours after you take levothyroxine. You do not want to give this medicine with the following medications. So 4 hours before, 4 hours after you take levothyroxine. Calcium carbonate, iron, caraphate, Kxalate, antacids that can contain aluminum, cholesterol-lowering drugs like Questrin. So these medications can interact. Do not 4 hours before or 4 hours after you take levothyroxine. Really important to have it by itself. Supportive measures, a high fiber diet, stool softeners, weight loss if indicated. You want to refer to an endocrinologist if the patient is pregnant, age 18 or less, is unresponsive to therapy. They're cardiac patients. If the patient has a goiter nodule or structural changes in the thyroid gland, presence of other endocrine disease, or patient has hyperthyroidism. Myxedema crisis, it may are severe hyperthermia, hypoventilation, hyponatremia, hypoglycemia, hypotension. Treatment is a large initial doses of levothyroxine IV and supportive measures. Myxedema crisis may lead to rhabdomyolysis or acute kidney failure, may be induced by an underlying infection, which can cause cardiac, respiratory, CNS, or cold exposure, or drug-induced. So may be induced by underlying infection, myxedema crisis, which can affect cardiac, respiratory, CNS, or drug use can cause myxedema crisis. Patients who are in myxedema crisis, just note they're usually very sensitive to opiates, and average doses may result in death. So it's important, FYI. Thyroid cancer. There's all different types. So the yearly incidence of thyroid cancer has been increased in the U.S. with the number of cases diagnosed annually reaching about 37,200, probably as a result of the wider use of CT, MRI, PET, and ultrasound that have incidental findings or small thyroid malignancy. So more scanning, we pick up thyroid cancer that normally we wouldn't pick up. So when we talk about follicular thyroid carcinoma, it counts for about 14% of thyroid malignancies. And follicular thyroid carcinoma is generally more aggressive than papillary. Really, but some follicular thyroid carcinomas secrete enough T4 to cause thyrotoxicosis. Metastases from follicular carcinomas are usually found in the neck nodes, lungs, and bones. They most avidly absorb iodine, making it possible to diagnose, scanning, and treat with radioactive iodine after total thyroidectomy. Discovery of medullary thyroid cancer makes genetic screening absolutely mandatory because a gene defect is usually discovered as the cause. Family members must be screened for that particular gene defect. Even without presence of gene defect, family members should have thyroid surveillance every 6 months. They should have examination of thyroid, TSH, and thyroid ultrasound. This does not concentrate iodine. This tumor may secrete calcitonin, corticotropin-releasing hormone, ACTH, prostaglandins, serotonin, amongst other prostaglandins, any of which can be used as tumor markers. So all of those medications can be used as tumor markers, all of those labs, I mean. Anaplastic usually appears in older patients as a rapidly enlarging mass. 13% of thyroid cancer is found on autopsy. It's most common in women, 3 out of 1 women. 3 to 1 with the male with a 3 to 1 ratio, and it's most common in women. And thyroid cancer the incidence is low at 0.4% of the US population. I'm sorry, risk factors. Exposure to ionizing radiation, atomic bomb, atomic testing. Chernobyl was an example of patients being exposed to radiation. Patients with radiation treatments or exposure to radiation were found to have enlarged thymus, enlarged tonsils, were used. The radiation treatments were given to children with enlarged thymus, enlarged tonsils, and acne, and 1 to 2 million were exposed. 1/3 developed thyroid nodule, and the other third treated for malignancy. Diagnostic testing. Certain characteristics of the thyroid nodule indicate that they could be cancerous. A single nodule in a thyroid gland that is otherwise apparently normal on ultrasound, a hard nodule, enlarged lymph nodes in the neck region, no decrease in nodule size after thyroid hormone medication, a nodule that is cold on radioactive iodine scan most likely is characteristic of cancer. A nodule that is very hard or fixed surrounding tissue is also a characteristic of cancer. So these are the diagnostic tests: an ultrasound, a fine needle aspiration biopsy. Not all patients have that. Serum calcitonin elevated, strong tumor marker for medullary thyroid cancer, a CT scan or an MRI. And very important, nucleus scans are useful in patients with indeterminate cytology, aka we don't know if it is malignant or benign after fine needle aspiration. Hot, hyperfunctioning nodules are benign in 98% of cases. So that's a really overactive thyroid is hyperfunctioning. It's a hot. Cold nodules have the highest risk of malignancy. In a patient with a thyroid nodule, most likely will need a fine needle aspiration biopsy. They will need a serum TSH to determine if the patient's hypo, hyper, or euthyroid. Most likely will need radio nucleus scans. An ultrasound can determine if the nodule is a cyst or a multinodule, can determine rate of growth, and it's more sensitive than a CT with neck metastasis. So know that. Serum calcitonin in patients who have a family history of medullary thyroid carcinoma. Initial management, thyroidectomy or near total thyroidectomy. For differentiated papillary or follicular carcinoma, a thyroidectomy with limited removal of cervical nodes is adequate. For medullary thyroid cancer, repeated neck dissections are often required. So if we were to give, if I was to give an overview of typical thyroid cancer treatment, first, a thyroid cancer most likely is usually diagnosed by a biopsy or sticking a needle into the thyroid nodule and removal of worrisome thyroid nodule by a surgeon. 2, the removed thyroid nodule is looked at under a microscope by a pathologist who will then decide if the nodule is benign. 95 to 99% of all nodules that are biopsied are benign. So those who are malignant, less than 1% of all nodules, and about 1 to 5% of nodules that are biopsied. So very low rate. Then the pathologist decides the type of thyroid cancer. Is this papillary follicular, mixed papillary follicular, medullary, or anaplastic? The entire thyroid is surgically removed. Sometimes this is done during the same operation where the biopsy takes place. Your patient will, he or she will assess the lymph node in the neck to see if they also need to be removed. The surgeon. In the case of an anaplastic thyroid cancer, your doctor will help you decide about the possibility of a tracheostomy. About 4 to 6 weeks after the thyroid has been removed, the patient will undergo radioactive iodine treatment. This is very simple and consists of taking a single pill in a dose that has been calculated for the patient. And then the patient does go home. Following thyroidectomy, radioactive iodine therapy to ablate any remnant of thyroid tissue, thyroid replacement therapy initiated to suppress TSH. Patients are followed up every 6 to 12 months by endocrinologist. We want to monitor for thyrotoxicosis, neck exam, chest x-ray, physical exam. Radioactive iodine therapy is only used if the tumor uptakes iodine. Additional treatment after surgery, candidates for radioactive treatment are usually younger in age, have well-differentiated tumor, have high radioactive uptake, have small metastasis. They have cancer location in lungs, and also stable or slow progression of the cancer disease. Repeated radioiodine treatment, response rate is 85% with 96% of complete responses seen with a cumulative activity of greater than 600 of the radiation. Additional treatment after surgery, candidates for other treatment modalities, older age, poorly differentiated tumor, no or low radioactive uptake, large mets, location in bones, rapidly progressing disease, patients with initial uptake but poor or no response to radioiodine treatment, and patients with no initial uptake of radioiodine, especially when disease is progressive. Other treatment modalities consist of ablation, thyroxine suppression, chemotherapy, and treatment of metastases. So that's it for me, guys. We'll be going over case studies, and I will see you shortly.